Hey everyone, this is Cameron Eldred. I am a doctorate in athletic training student through Indiana State University, and today we're going to be talking about my personal reflection on my ankle injury decision-making skills. So a little bit about myself. I'm a recent graduate from the University of Utah, and like I said, I'm now a student in the doctorate in athletic training program through Indiana State University. Right now I work with a small rural consolidated school in Indiana, meaning I work with patients K through 12, mostly high school and junior high patients, but every now and again with fifth and sixth graders. Now I want to answer the question why I'm doing this reflection, but before we do, I want to talk about a quote from Michael Jordan. He said, "I visualized where I wanted to be, what kind of player I wanted to become. I knew exactly where I wanted to go, and I focused on getting there." So part of personal reflection is playing into this. You need to be able to visualize where you want to be and where you want to go and how you're going to do it. So the first part of reflection is making sense of things. Getting your thoughts on paper can help you understand why you're feeling a certain way, and it makes those feelings a little bit easier to navigate, and we don't get as frustrated or as clustered. That leads us to finding answers. It leads us to thinking of, what we already know, because we already know the answer. It's just a matter of being able to dig deep and find it, which then leads us to, well, maybe my way of thinking is in need of change. So self-reflection brings on this change. It makes you critically look at everything that you've been doing and find where it's weakest. So in my clinical experience, this will help change the way that I do things. But then we need to recognize the change. We need to recognize that there's an issue and we need to move on with it. But once we do that, we need to live with more intention. So this is all about setting goals, making milestones, reaching those goals, and starting back over again with a new goal. So the first thing that I wanted to talk about is going to be my current style that I use in order to evaluate an ankle injury or a lower extremity injury. So the first thing that I do when a patient walks into my clinic is I start going over a history with them. So chief complaint, mechanism of injury, any unusual sounds or sensations, type and location of pain, medications they've been taking, any previous injury to the bilateral limb, things like that. So I get your regular history. Next thing I look at is observation. Swelling, deformity, abnormalities, discoloration, any scars or calluses or anything like that that might lead me to a possible differential diagnosis of maybe something else is causing the issue. But I also look at like gait, weight bearing, ankle motion, and I also talk to them, of course, about training history, if there's been any change in their current regimen. At this point, I like to do some palpation. I like to be able to rule out or look at any possible deformities. I like to be able to look at all of the soft tissue and what may be going on there. I look at tibial crest, fibula, peroneal muscles, tendons, lateral and medial malleoli, all of the ligaments, gastroc, soleus, or some other things I look at, Achilles tendon, calcaneus. All of those things are things that I look at when I'm palpating, because all of those are important structures that can lead to a differential diagnosis, because somebody may come in and have some type of a lateral ankle sprain, or they've had, chronic ankle instability, but there could be an underlying issue that's causing that. So we need to look at those differential diagnoses. After I kind of go through all of those things in my head and I'm making mental checklists, I look at their range of motion. This is active range of motion first to see if the patient can actually move the affected limb. And then I move on to passive range of motion. And for all of this, I look at plantar flexion, dorsiflexion, hindfoot inversion, eversion, forefoot inversion and eversion, as well as toe flexion and extension. And I always compare bilaterally. So I start with active, then I move to passive, because if they can't do it actively, I'm going to try to put them through the motion. And if it still hurts, then I'm not going to have them do manual resistance next, which would be my strength testing. But if they're able to, then I'm going to go ahead and I'm going to perform manual resistance, same motions as I did during the active range of motion. And again, I'm going to check bilaterally for any deficit, pain, weakness, anything like that. The next thing that I do is I look at special tests I mean, there's a multitude of these for the lower extremity, so I'm not going to go into great detail, but I try to selectively go through and decide, okay, this is the injury that we're looking at, and these are the special tests that I need to select for it. And every now and again, I might throw in a couple of extra tests just to help rule out any differential diagnoses. And then lastly, of course, I do functional testing just to get an idea of maybe where they're at function-wise. Now, some things that are missing from this that I started realizing is I don't look at joint mobility. I also don't really think about the whole neurovascular portion of this. You know, what's affected by S1, S2, you know, the lumbar, all of those things. So I need to focus a lot on those neurovascular innervations, you know, what's causing what goes where. Measuring range of motion, I look at range of motion, but I don't actually measure it with a goniometer. Order of operations, I tend to bounce all over the place sometimes. I try to have a more systematic approach, but a lot of the time it doesn't work as well as I want it to. I need to also focus in on the moment. I have a bad habit of gathering redundant information. So information that doesn't play into the injury, information that doesn't matter. I tend to try to talk to the patient that I'm working with on a more personal level rather than a professional level. And this is something that I've noticed a lot over the last few weeks as I become more and more comfortable with being a clinician. And then I also need to begin incorporating outcomes in everything. Now, why do I do these things? I'm a recent graduate. I'm still trying to find my way. I listen and, you know, try to pay attention to what other people do. So like other influences. I have a need for acceptance from the patients that I work with. So I kind of get off on tangents with them. I also try to be very by the book, and this doesn't work in the athletic training field as often as we would want it to, because no injury is going to be exactly by the book. And then I also have some self-doubt, especially when it comes to doing the outcomes. You know, will this actually work? Does the information actually benefit me? Why am I doing this? So all of these things are playing into why I do what I do and the way that I do it. Now I need to improve my process. So Thomas Paine said, the real man smiles in trouble, gathers strength from distress, and grows brave by reflection. So every day I should be reviewing and reflecting the things that I'm doing within my own clinical practice. Did I do things in a certain order? Did I like the way that I did things? Was this beneficial for the patient? I should set out measurement tools, because when things are out of sight, they're out of mind. So if I put out goniometers, I'm going to be more willing to measure those range of motion. I'm going to be more willing to take the measurements that I should be taking in the first place. I also need to slow down and focus on what's important. I need to stop getting off on tangents and thinking that the patient needs me as a friend rather than a clinician. So I need to slow down, focus on what's important with the patient, focus on them, focus on the issue at hand. These things are going to help me get into more of a rhythm, and it's going to help me establish more of a clinical competence when it comes to doing an evaluation. I'm going to have more of a set process. And then lastly, I need to set goals, and I need to take precautions, and I need to take the steps that are necessary to reach those goals. So every week I should be writing down, this week I want to review and reflect on everything. This week I want to make sure that I have all of my tools set out and that I use them as much as possible. But then I need to decide every day, okay, who am I going to use these with because I'm working with patients, and who could I use them on? And then I really need to write myself a note and stick it on the wall, and it just needs to say, slow down, focus on what's important. Because every time that a patient comes in, I can glance at that and I can go through that process in my head. So I just wanted to say thank you for this opportunity. It's been a real treat to be able to look at my own practice and reflect on the things that I know that I need to improve upon. And again, thank you to the Doctorate in Athletic Training program through Indiana State for giving me this opportunity, because I wouldn't be where I'm at today without them. So again, thank you so much, and I appreciate this.